Well, thank you very much, Dr. Kaiser, for those opening remarks. And I want to also thank the National Academy for their willingness to put this into their list of priorities and to do this work in collaboration with us. And thank the Planning Committee and the session speakers as well. Dr. Matthews and I have the tasks of leading access, both internal to VA, my job, and in the community components that Dr. Matthews will speak in a few moments. This is really, this National Academy workshop is really a part of a strategic access management initiative and a series of things that we're really participating in, engaging in both within the VA and with external stakeholders to really help guide our way forward in VA to seek a better understanding of what are the key components of access, looking for how we expand our thinking and considerations as we're moving into a world of technology, particularly with in context of the last few months, and then look for ways that this could be generalizable outside of this workshop and some of our efforts and how they can essentially be what might be generalizable and meaningful in healthcare overall. So I'm going to, next slide, please, give you a little bit of an overview of VHA to make sure that folks on this call, while many of you may be from the VA or have worked with the VA, I want to level set that. We're going to touch on care in the community. What does that mean for us? How we've been measuring access in VA, considerations for how we might move forward with that, and then speak to an access roundtable that we had in January that some of the participants and speakers in this workshop engaged. So next slide, please. In brief, the Department of Veterans Affairs has 3 branches, really, and the healthcare division, the Veterans Health Administration, is by and large the largest component. We do serve to have veterans benefits as well as a veterans memorial, the National Cemetery Services. And so really VA, we use that terminology meaning the healthcare administration, but recognizing that we work and support veterans with benefits as well as cemetery services. Next slide, please. A little bit more about the VA mission, and that is really obviously care delivery, but we really have a significant responsibility in training. Many of you on this call and participating with us may have trained in part at a VA. That has been, it is a critical mission for us as well, and a substantial one. I think at least, 25 or 30% of the trainees out there, I think at least in medical education, maybe Dr. Kaiser, you know this more specific number than I do, but have been through the VA as part of their healthcare training. And then research is also a critical mission for us, both bench research, clinical research, and health services research. And then, as many of you have seen over the last few months, what we call our 4th mission has been to take care of non-veterans in times of war or national emergency. We had our medical centers taking care of many civilians in New York and other areas, New Orleans, in the last few months, and that is what we call our 4th mission. So next slide, please. Our customers, who do we take care of? We currently have enrolled a little bit more than 9 million veterans. 1 in 12 of them is a woman, and we also do provide benefits for spouses, survivors, and dependents of veterans. And as Dr. Kaiser alluded to, really, we do serve a bit of a unique population and need to ensure that we have those care needs met. 25% of our veterans live in rural or highly rural areas. They're older than non-veterans. The median age of the veteran population receiving care is 64 versus 44. And then, as you would imagine, there are unique needs and issues related to mental health, post-traumatic stress disorder, traumatic brain injuries. Of a lot of interest is a high prevalence of chronic pain and also a high prevalence of complex chronic illness. By that, I mean it's really high prevalence of multiple morbidities, and including mental health as as one of the comorbidities comprising the multiple complex chronic illnesses. We really are divided into now 18 VA integrated service networks on the right. You could see that broken up, and it really is between 8 and 11 medical centers is really what a VISN is comprised of. And we cover territories such as Guam, American Samoa, Philippines, Puerto Rico, Alaska, Hawaii. So that's really the geographic expanse of where we're delivering healthcare. Next slide, please. So really 160, sometimes you see 170 medical centers, depending on how you're counting some of the smaller medical centers, over 1,000 outpatient sites of care. Last year, almost 60 million completed appointments. Okay. And you can see that we have a substantial amount of staff. Okay, let's keep moving. We've been traditionally focusing on these metrics. While we do look at veteran trust, we have been really a bit focused in face-to-face visits, wait times, same-day appointments, urgent referral to a specialist. Next slide, please. So what else are we doing in this arena? We're looking at, next slide, please. And as a part or component of access, we're looking at how we use text messaging to engage with veterans and manage some of their appointments. You can reference these slides. I want to make sure that we hear from Dr. Matthews. Next slide. Looking at same-day services and working with the National Quality Forum and Atlas to try to understand if we can measure things differently than a face-to-face visit as a same-day service. This has been a priority for ours over the last few years. Looking at measurement, it's part of our overall access strategy. Next slide. Have publicly reported wait time information, looking at underserved communities, and looking at how we expand telehealth. I'm trying to catch up a little bit here, and then turn to, I think, the next slide. And I don't know, Cameron, if you want to start to speak a bit to the referral coordination. We really, this is a partnership in looking at the coordination of and care needs with veterans who are maybe eligible to go into the community, having essentially care teams that have the conversation about care options in the VA or in the community, and really empower the veterans to help make decisions that meet their needs. Do you want to comment on that? And I think then the next couple of slides are yours.
Sure. Good morning, everyone. Dr. Matthews here. Yeah, referral coordination for us is pretty critical in the effort of really creating some integration of services, which is from a veteran standpoint, of course, with the goal of providing veteran-centered care, that regardless of whether they receive that care within the VA, by telehealth means, or in the community, that we want to be able to coordinate that care in as efficient and effective way as possible. So the coordination teams at the facilities are meant to provide really transparency on all of the options so the veteran can feel empowered to make those decisions, as opposed to the ordering provider, for instance, making that decision without there being really disclosure of all the different opportunities that are available. So let's jump to the next slide. So community care really as a concept is something I think other health systems in the private sector definitely are familiar with, but not necessarily in the same sort of respect. With community care, we do have specific authority, really from a financial perspective, to pay for care that is not provided within the VA. That concept has really transformed over decades. We've been doing so since the 1940s. And with the introduction of the Choice program back in 2015, and now really a lot of transformation under the Mission Act of 2018, we've really gotten to higher levels of efficiency. And the concept is, again, to integrate how we provide the VA services versus how we then refer out to the community. So under the Mission Act, we were able to update a lot of the rules regarding how community care can be provided, how eligibility for community care is determined. And these are outlined here. Some of the more, I would say, controversial pieces of the Choice program, we really sought to build out a better sense of access. And again, I know Dr. Kaiser even said we need to be discussing what that definition is. But we call these our access criteria, that for specific types of care, there are wait times and drive times in which a veteran becomes eligible to then be referred to the community. They can then elect to either take advantage of those opportunities or stay with the VA. It is not a requirement. But the difference here from the private sector, of course, is that this is not open access to the network. They have to be deemed eligible through a set of rules that are now set by federal regulation to then receive that care. So wait times and drive times are displayed here. There are other criteria as well. Specific services we don't offer in-house, meaning maternity, IVF coverage for female veterans and spouses of veterans. And then quality standards, that's something that could probably, actually should, and I believe has taken several other Academy days of conversation, but how we actually look at the comparison of the quality of care within the VA to the community. And in some circumstances, the Mission Act authorizes us to actually make referrals of veterans to the community based on quality discrepancies, essentially. Next slide. So the different factors, and these are, again, I could probably spend several hours on this, and I know we have a lot of other information to cover on this panel, but factors impacting how veterans actually have access to community care. It's a decision for the veteran. They can choose to exercise their eligibility, but at times there are longer wait times for care in the community. A lot of times, we have the fortune, especially I would say in some of specialty services as well as mental health, we do have shorter wait times. So how are veterans really able to access that information and make decisions? And so really their level of empowerment is dependent on an information exchange there, where indeed, as we've mentioned earlier, wait times aren't shared in the private sector, and whereas ours are publicly reported. So how that transparency can actually help the veteran, we are regularly looking to improve upon. 70% of veterans also have other health insurance coverage. So yes, they are eligible and enrolled in VHA. Yes, they can take advantage if they are eligible really for particular services for community care, because we purchase care on an episodic basis. But then 70% of them have third-party coverage, whether it be Medicare, TRICARE, through DOD as a retiree or other beneficiary, or other private sector coverage. We have very little transparency. VA is not involved in that financial relationship. The medical record sharing is quite limited because, of course, as a payer that's not actually involved with that relationship, we really aren't party to those communications. So our ability to track quality, our ability to really look at access to care is limited due to really, rightfully so, the broadened opportunities that veterans have, because they are not required to solely have VA coverage and use VA coverage. Second, our emergency care coverage has some difficulties in the sense, again, that it's not open-ended access to the network. There's a lot of restrictions by legislation that I hope to be working with our colleagues on the Hill to help simplify, but there are different circumstances in which veterans can have coverage for emergency care, sometimes based, actually a large part based on their service connection. And that's not necessarily a concept we discussed earlier, but whether or not their injury illnesses are related to their actual service makes a difference as to how their emergency care is covered. And that, of course, is very different from the private sector. There is no parallel in the private sector. And it's difficult for a lot of veterans to understand how that coverage actually functions. The urgent care benefit is a new piece under the Mission Act. We now have the ability for veterans to seek out care without authorization. As I discussed, not only do you need to have eligibility for community care as an individual veteran, but you also have to receive a referral with other payers to be seen in the community. It needs to be deemed clinically appropriate and the like. Urgent care actually falls outside of that requirement. And with some changes during the last couple of months with COVID, it's actually been quite a well-utilized benefit. We have a network under our third-party administrators of more than 6,000 urgent care centers across the country, and we really do think that this has improved access to care for a lot of veterans. We're looking at the data. Is this actually providing some cost savings due to diversion away from emergency care, for instance? That is still being analyzed by the claims data as it comes in. But we really are excited to have been able to offer this benefit to veterans. But in many ways, it has improved access. But at the same time, particularly as a primary care doc, we need to question continuity of care, especially with a lot of our veterans having really more severe chronic illnesses, comorbidities, mental health concerns, how urgent care, when it's really that quick episodic sort of experience, how that actually might potentially worsen other outcomes when there isn't medication reconciliation or transitions of care back to a primary care setting. That's, of course, concern from a quality standpoint. And then lastly, a factor that definitely impacts access under the Mission Act, we are, of course, required to not only assure the quality of care, not just access to care in the community, but the quality of that care that veterans receive in the community, how we measure that. And that, of course, is a much larger conversation going really throughout the health industry now. But there are requirements under the Mission Act to also have competency standards for particular actual illnesses. The legislative requirement is that if a community provider is treating PTSD, military sexual trauma, or traumatic brain injury, as well as other veteran-specific conditions, they have to exhibit some competency. So we've attached that to certain provider types, certain specialties. We've developed trainings. We've also had military competence, general training for other providers that we are seeking to implement throughout the network. But that, of course, balances out potentially against our ability to provide access in the community if indeed providers aren't appropriately incentivized to take part in this competency training. That could, of course, be limiting how many providers in the community have the ability to treat veterans. So these are just some factors that we are really seeking out input, as well as hoping to fine tune in the coming months and years. But at the same time, I think this brings a lot of positivity from the Mission Act, and certainly over how we've deployed community care in the past. But Susan, I'll pass it on to you.
Okay, next slide, please. So as many of you hopefully can see, we are really have such a large number of patients and geographic catchment area. We have such a large integrated network, which is what we say between both in VHA care and within the community care, that it sometimes is challenging to really get our arms around that. And we're really seeking, although I understand the limitations of a virtual meeting, to have some input and to help really guide our way forward. One such effort to guide our way forward was a roundtable event that happened in January of 2020. Next slide. It was it was really the goal of which was really to get perspectives on access from a diverse, predominantly non-VA group, looking at primary care, mental health, and specialty care access, and really chaired by Dr. Kaiser. We had invited folks from Kaiser Permanente, National Quality Forum, New York Health and Hospitals, Press Ganey, Walmart, CVS Healthcare, Microsoft Healthcare, Defense Health Agency, and you can see HRSA, HRQ, and more. And we did have some VA folks there, but the goal was really to hear from external stakeholders who are emerging or continue to be in the healthcare arena, and how are they approaching this work. Next slide. Here's really access to care should be defined by more than just wait times, including especially how patients feel about the timeliness of their care. It was a one-day meeting, and you can see some of the participants here. Dr. Kaiser's in there, and I think you can see Tom Lee and Cameron's deputy, Mark Upton, there in our discussion. And the outcome of that, which we hope would, for those of you that participated, continue on. Next slide, please. During this conversation and this meeting, and I really distilled it down quite significantly, and we can discuss this a little bit more, but really number two is really getting beyond wait times. What else really does matter as we look at what access really means now and into the future. We know that continuity, as Cameron mentioned, is of critical importance. How are we looking at virtual care? That's really exploded in the last few months, and we have a session later today about that specifically. Cameron also touched on quality, and access is a key component of quality. And then really looking at, in number one, the orientation toward the patient, and how do they feel about the doctor visit? Is that really how long it takes to get to the doctor's visit? Is that the only thing that matters? We really need to, and a number of high-performing healthcare systems have developed patient experience offices, look for and really try to engender trust, empathy, coordination, and communication. And how do we capture this feeling that the veteran is really, really a part of the healthcare system in which they're getting care, that they're really connected to it, and how do we measure some of that aspect? And then on to number three, I think I wanted to briefly touch on the fact that is everything really equal? Is getting a follow-up screening colonoscopy that might be due in a year, but if it's a year and a month, does that matter versus a new lung mass? And so how do we look at measuring what I like to say, what matters maybe most to patients? How do we determine what matters most to patients? And measure that from that patient perspective. And we touched on that there's not a lot of good definition, and the roundtable folks, really the outside stakeholders, confirm that. So I think I have one more slide. Or no slides. But I will say really that last slide really is a springboard just to really tie up a couple of things that I really wanted to ask the group. And that is really in the portfolio of measures. I want to focus on what is it that you would recommend that we put in there. What do we take out? What do we add as we move forward? Because I really do believe, and this was brought up at the roundtable, that the VA has the ability to try and test a lot of these things, and then potentially have this generalizability or applicability to other healthcare systems. We want to be in that position of helping to explore some of this work, contribute this work, and then share that with the outside of VA. And we're looking to you really in this in this National Academy workshop and over the next day and a half to help us further understand where to go. And emphasis then in conclusion on the number one here, that the patient component, and how do we look toward technology over the last few months and incorporate that into our way forward and what we're going to focus on and what we're going to measure. So thank you for participating. Look forward to some further conversation, and I will turn it back to you. I think, Cheryl. I think it's Cheryl who goes next.
Well, let me, while we are transitioning here to Cheryl, just make two quick comments. One is just in the way of kind of level setting for folks who are less familiar with the VA than some others, is that not everyone is eligible for VA care, or not every veteran is eligible for VA care. And while Dr. Matthews talked about eligibility for community care, it's actually that there's only a subset of veterans who are truly eligible for VA care, and we may want to talk more about that later.